arthroscopic surgery. I was a bit surprised about Perthes disease. Essentially, the reason why I was surprised is the fact that Perthes disease is actually a disease of the West. It's a problem that occurs in Europe, North America, and parts of the Far East. The continent of Africa is not affected by and large with Perthes, unless my reading of the literature is incorrect at the moment, because normally we don't tend to see people of African origin having Perthes. Is this something that you guys see a fair amount of, or is this really for the exam, which tends to be something else that comes up? Just our interest.
Saqif, I think you've probably answered your question, but go on. Anybody's going to tell us why we're talking about Perthes disease today?
Good evening, sirs. Thank you very much for organizing this. I actually came up with a list of topics.
Yeah.
Mark Baguiola is my name, Senior Registrar of Orthopedics and Trauma. I put Perthes on the list because we don't see it commonly. However, it comes up on the tests, and it's also one of the other differential diagnoses for hip pathology in pediatric patients.
Right.
And we don't know a lot about it, so that's why I put it up.
Okay. No, that's okay.
That's a fair answer.
Thank you.
Okay, well, I think that as we normally do, it's 10 past now, so we might as well make a start.
Yeah, so we'll kick off with Perthes first.
Are you trying to share your screen?
Yeah.
Okay, it should be, okay, you've got it.
Yeah, okay. Okay, anyway, afternoon, everybody. For those who haven't met me, I know I did a previous session with you guys a few months ago. I'm Saqif Hossain. I'm an orthopedic consultant currently based in Manchester. I'm actually at the Royal Oldham Hospital in Manchester, which is part of a number of organizations, one being Pennine Acute Trust, and the other one is Northern Care Alliance Group. I graduated from University of Ibadan in 1989, and then came into the UK, did my surgical training and my orthopedic training, and I've been a consultant for about 16 years now. I have a special interest in hip and knee pathology. I do a lot of knee surgery. That's where my main interest tends to lie. And as you guys were going on, you wanted us to discuss the management of Perthes disease. The proper name for it really is Legg-Calves-Perthes disease. I think we need to give recognition to all of those guys who actually describe this condition, which we don't seem to do very often. Why isn't it moving? Aha. So essentially, what is Perthes disease? It's essentially a self-limiting condition. It's osteochondrosis of the femoral head. The etiology is not known. It tends to affect children. And essentially was actually described by Arthur Clegg and Wallstrom in 1909 first. So it actually should be called a leg disease rather than a Perthes disease, because George Perthes and Jacques Calves actually described it the year later. But I guess Perthes had more oomph than the rest, than Legg, and hence it's now called Perthes disease. So there are many names that are given to Perthes disease. So Perthes disease is one of them. The other one is the leg stress fracture of the femoral head, osteochondritis deformans, osteochondrosis of the hip, pseudocoxalgia, coxa plana. There are several names given to this, but I think the commonest one that we tend to know it by is still Perthes disease. Okay, so what's the epidemiology? And that was what I was going on about. It tends to be commoner in males, is at a ratio of 4:1. The commonest age group is between the ages of 4 and 8, but it can occur in younger and older children. There is a small number of people who have a positive family history. There has been some association with breech and transverse presentations. And it tends to be more in Eskimos, Japanese, and Central Europeans. And as I was saying, it was uncommon in children of African origin. There is an association with low socioeconomic status. We're not sure why. And again, an interesting fact is that the third or the fourth child is more likely to get Perthes. Again, not sure why that is the case. And they tend to be children who are of short stature and have a retarded bone age, which may be related to the low socioeconomic status. And again, if you look at it, low socioeconomic status, it is the third or the fourth child, they're likely to be even more affected. So, as I was saying, the etiology is not known. There are many theories, and whenever there are theories, we just don't know what the cause is. Some have suggested there's a coagulation disorder, and there has been some association with things like protein S and protein C deficiency. It is thought that the arterial status and the blood supply to the head is in some way affected. Others have talked about abnormal venous drainage, which is very similar to AVN in adults, where we talk about venous hypertension. Some have talked about there's an abnormal growth and development. Trauma has been thought as a possible cause. Again, I must say, in my experience of seeing these patients, I've not heard of a single patient who presented with any form of trauma. It's thought that the children tend to have hyperactivity or attention disorders, which currently in the West seems to be quite a common thing. Everybody seems to be labeled with some form of disorder like that in children. As we said, that 10% of patients have a family history. It possibly could be genetic. Could it be environmental? That the very fact that it only occurs in Europe and the Far East. And we do know that there is an element of synovitis, and all of these things can actually end up causing synovitis around the hip. And this is essentially a picture of a Perthes disease patient. It's affecting the left hip. The right hip is normal. The left hip, you can see that the femoral head is disintegrating, and that's usually the classic X-rays we tend to see in Perthes disease. So if you look at each of these things, so if you look at vascular supply, this is thought to, as I was saying, causes increase in intra-articular pressure, increases in intraosseous pressure, so that impairs the venous drainage, causing the pressure in the bone as well as in the joint to increase, and this reduces blood supply. There has been an association of factor C and factor S deficiency. They have increased levels of lipoprotein and thrombogenic substances. But again, these are very academic, and I don't think any one of us actually do any of these tests when we see patients with hip pain. So I wouldn't go too much on those things. So the blood supply, as we know, the blood supply of the femoral head, one of the things that is asked in most exams, both in the UK, is asked both at the MRCS level as well as the FRCS level, is, the supply of the femoral head comes from three sources. You have the metaphyseal artery, which is essentially what goes in the bone, so an intraosseous supply. Then you have the artery in the capsule of the hip, which are the retinacular vessels, and then the artery of the ligamentum teres. Now, the artery of the ligamentum teres is a good one in the fact that it's only active really in the very young children, and as you grow older, that blood supply disappears. Although when I do hip replacements, I do find that it still bleeds, even in a 70-year-old person. So essentially the pathogenesis behind that is the fact that if you look at the femoral head, So that's the femoral head. That's the blood supply coming in. And something happens in this area that tends to cause this situation where the blood supply is not right, okay? And therefore causes some element of bone infarction. And whether it's this vessel that's caused a problem, which is the retinacular vessel or the metaphyseal vessel, we're not entirely sure. So what are the clinical features? They're usually mild or intermittent pain they tend to get. They may present with a limp. The pain can sometimes be quite acute or insidious in onset. The classic presentation really is that you have this 4 or 5-year-old boy who presents with a painless limp. And when you move the hip around, it tends to cause more pain. And when you rest it, it's relieved by it. So they usually present with an antalgic gait. For those who don't know what an antalgic gait is a gait when you actually spend little time on one leg in the gait cycle. So essentially, because they can't, either it's painful, they tend to spend less time on that leg. So they may present with muscle spasms secondary to hip irritation. They usually have reduced abduction and rotation of the hip. And as we were saying, that many of these children are of short stature. And as it progresses, they may develop a fixed flexion deformity of the hip. When you do a Trendelenburg's test, which is again a test that is always asked for in the exams, they are positive. I'm sure you guys know what a Trendelenburg's is. What are the differentials? And you do need to discuss the differentials, especially in your setting. Things like septic arthritis of the hip, TB of the hip, obviously trauma. There is a condition called an irritable hip, which is a transient synovitis of the hip. In slightly older children, it could be slipped upper femoral epiphysis. Sickle cell disease can cause a similar sort of presentation. And other rarer things like Gaucher's disease, lymphomas, other hemoglobinopathies like hemoglobin Punjab and things like that. And then obviously minor trauma such as a groin sprain can give you very similar pictures. And the idea is to find out what it is. And as Prof. Ajao told us when we were there, common things occur commonly. And so you should always look at that. So what are the investigations you do? Usually we'll get an X-ray, an AP, and frog leg lateral. You need to do an ultrasound scan, mainly because of the fact that your main differential really is a septic hip, and to see if there is any effusion in the hip. And if you're able to, if there is an effusion, attempt to aspirate that hip under ultrasound guidance. MR scans and arthrograms are done much later. MR scans are really to find out, to make a firm diagnosis, and arthrogram is to find out, is to really plan management, as we will speak in a little while. So arthrogram is essentially what an arthrogram is essentially you inject a dye into the hip and then look at the hip in different levels of abduction and rotation to see where the hip is best contained in the joint, because they usually have an element of incongruity of the hip, okay? And it's also useful to see if the patient has a fragmentary reparative stages, which we'll go on to in a second, as what the stages of this condition are. So what are the stages? There are really 4 stages. There is the stage of synovitis, which is the inflammation, the early stages. You then have the stage of avascular necrosis. And then once the femoral head has necrosis, it starts to fragment and resorb. And finally, it then heals up and forms an abnormal hip. So in the synovitis stage, it usually lasts for about 1 to 3 weeks. The synovium is swollen, is hyperemic under the microscope. There is no inflammatory cells, because obviously if it was a septic hip, you would have lots of inflammatory cells, but in this situation, there are no inflammatory cells, and that's the main thing. And then, as I was saying, they usually tend to have a little bit of fluid in there, which if you did see it on the ultrasound scan, attempt to aspirate it. And in the first stage, the x-rays are normal. So the next stage is the avascular stage, and this is usually when most patients actually tend to present in our setting, is that it usually lasts for about 6 to 12 months. It involves only a portion of the nucleus, and it's usually situated in the anterior bit of the nucleus, but it can affect all of the nucleus as well. The bone architecture is normal, but the lacunae are vacant and empty. The bone trabeculae are crushed into minute fragments and compressed into a compact mass, which subsequently will start to fragment. The gross appearance and contour of the femoral head remains unchanged. If you actually open the hip, it actually looks fairly normal. So the next stage is the fragmentary, the fragmentation or the resorption stage, where those little bits are now fragmenting up and forming little islands. So this usually lasts for about 2 to 3 years. Resorption of the necrotic bone and replacement with viable bone is what is happening. There are subchondral fractures with multiple trabecular fragments that are compressed together, but these fragments are bigger, which is what I showed you on the x-rays earlier. And I'll show you some of these pictures in a second. And in the late stage is when it starts to heal. Normal bone is forming and slowly replaces it. The bone is usually woven bone, and so it's immature. The entire ossific nucleus may become deformed and look like a mushroom. And because of the fact that femoral head is enlarged, hence the term coxa magna is used to describe that, coxa being hip and magna being large. So there are many classifications of this condition. And again, whenever you have multiple classifications, there usually isn't a correct one. These are all the different ones. The one we tend to use really is the Herring's classification. And that's the one that is, it's actually the easiest one to use as well. And which essentially uses what's called the lateral pillar. And I'll show you a picture in a second of what these are. So the lateral pillar, in fact, we'll go to that. So you have A, B, and C. And essentially, this is what it is. So if the lateral pillar, which is this, is fully there, then it's a Herring A. And they tend to have a good prognosis. If in the Herring B is when it is more than 50% is still intact. So anything between 50 and 100% or 99% of the lateral pillar is collapsed, then that's a Herring B. And then if it is less than 50%, which is this picture, that's a Herring C. And Herring C usually tend to have a poor prognosis. So there are some other signs that go with with Perthes disease. There is something called the Catterall's head at risk sign. Catterall was a pediatric orthopedic surgeon down south. Well, to us is down south in the UK, and he described a few signs, and these signs, the presence of these signs, tended to suggest a poor prognosis. The first was Gage's sign, and Gage's sign is really, if you look at this X-ray of the hip, there is a little bit that's taken out of here, and I've put a little arrow on that or a line on that to show what that is. That little triangle of bone has disappeared, and that tends to suggest that, you know, this has a poor prognosis. So that's called the Gage's sign. There's a lateral calcification, which is this bit here. There's a very little lateral calcification that's there, and in the presence of that, is what it actually means is the femoral head has been extruded out, and there's a bit of calcification outside the hip itself. Then, if the head subluxes laterally, and if you look at this X-ray, if you draw a line down from there to there, there's this bit of the head that's outside the hip, And that suggests, that, again, that that would have a poor prognosis. The physis is usually an oblique line, which is this line here. And as it becomes more and more horizontal, as in this case, you can see that the physis is actually completely horizontal. That is also regarded as a poor prognostic sign. And then if you have diffuse metaphyseal reaction, as we can see here, there is some reaction in this whole area. And that again suggests that that would have a poor prognosis. So other poor prognostic factors are if you make a diagnosis of Perthes disease in a child who's over the age of 6, if the child is female, boys tend to have a better outcome. And the presence, as we said, of all these Catterall's head at risk sign. And if at the point of diagnosis, you have a Herring type C, these all are regarded as poor prognostic factors. And such needs to be explained to the parents and that the treatment may need to be more aggressive for those children. So what treatments do we have? So the objectives of treating these patients is to produce a normal femoral head and neck, to produce a normal acetabulum, a congruent hip, which is fully mobile, and prevent early onset degenerative arthritis. So that's what we're trying to achieve in these children, because you don't actually want to be doing hip replacements in young people. So by and large, in patients who have a Herring type A or B, so Herring type A being that the lateral pillar is completely intact, or B where more than 50% of the lateral pillar is intact, no treatment is really needed. These patients can be treated symptomatically. So what you try and do in these patients is to restore and maintain mobility. So, and in the active phase, you try and, sorry, let me go back again one step. So if you look at the phases of treatment, in that bit, I said in the Herring's type A and B, we're going to be treating them symptomatically. I think my slides got all mixed up there. But if you look at the different phases, in the initial phase, you tend to try and restore and maintain mobility of the hip. In the active phase, you want to contain the hip in order to maintain full mobility. And in the reconstructive phase, you're trying to correct residual deformities, where, as they say, the horse has bolted at that point. So essentially, when you do nothing, is essentially you do frequent clinical and radiological assessments to make sure that they're not progressing. You treat them symptomatically with bed rest, abduction and traction in some cases. You can use non-steroidals if indicated, crutches, and then stretching exercises with physiotherapy in order to maintain the range of motion of that hip. If deformation occurs during the phase of fragmentation and early ossification, then, so what you're trying to do is to prevent the deformation, and you want to contain the head inside there so that you don't have any late fragmentation of the head. So in terms of containment, so you want, which is the next phase, you can still have conservative treatment even in slightly advanced cases. So the conservative, slightly more aggressive conservative treatment is to use this sort of plaster, the so-called broomstick plaster. You can use braces as well. The plaster seems to work okay. It's really a spiker, a hip spiker with a wooden stick between the two legs to keep the hip abducted, so that you can maintain the continuity of the hip itself. There are these braces that can be used in older children who are more mobile. Well, that's again keeping the hip abducted and they can still.
Saqif, just hold on. Can you please turn off all your microphones, please? There's quite a lot of noises coming up. Turn off all your microphones, please, everybody, please. Sorry, Saqif, continue.
Yeah. So one of the surgical treatments the first thing to say is that if I put my cards down, I don't do these because in our case, our pediatric orthopedic surgeons tend to do them. But the principles are fairly straightforward, is that you can either, what you want to do is put the hip back into joints. So you can either do a pelvic osteotomy or a femoral osteotomy. So those are really your options surgically. So this is a femoral osteotomy, and it's technically easier. What you do is you do a subtrochanteric, or just around the lesser trochanters where you do your osteotomy. You then turn the hip and give 20 degrees of varus and 20 degrees of internal rotation of the hip. And then in order, once you've done that, you've got to do an arthrogram to make sure that you have achieved what you aim to achieve, and then fix it with a plate, such as this, okay? It can be done up to the age of 12, and the prerequisite for a femoral osteotomy is that you have to have a full range of movement of the hip. If you don't, then this will not work. Then you have the pelvic osteotomies, and there are many pelvic osteotomies. The commonest one that we tend to do is the Salter's osteotomy, and the Salter's osteotomy is really an osteotomy above, through the iliac crest, through the greatest sciatic notch. You do an osteotomy and then turn that bit over so as to have coverage of the femoral head. So you reorientate the acetabulum completely. You can then fix it with either screws or wires, and then post-operatively, you've got to put them into a hip spica. You can do a shelf osteotomy, and a shelf osteotomy is more of a salvage procedure. And what that does is that if you look at this X-ray, this bit of the hip is sitting outside the hip. So what you want to do is to try and achieve this. So what you do is you do an osteotomy of the lateral part of the ilium and turn it down, and then fill that bit here with bone graft. As I said, it is a salvage procedure because of the fact that what you're getting is the femoral head is articulating not with articular cartilage of the acetabulum, but with bone of the ilium. Then you've got the Chiari osteotomy, and the Chiari osteotomy is a displacement osteotomy. What you do is you have an osteotomy right on the top of the acetabulum, and you shift the whole of the proximal femur and the acetabulum medially, so that you have an area which then covers the head. As in this case, I think that they've actually overdone it on this X-ray from what I can see, and then you fix it with screws as well. Some of you may remember Bud Chiari malformations. It's the same Chiari that described this osteotomy, by the way. So looking at the specific guidelines, looking at how you're going to treat these patients. So if patients have favorable outcome, in other words, less than half the head is affected, there is no extrusion, it's a herring A or B, no specific treatment other than symptomatic treatment, and you require periodic review. If you have unfavorable outcomes, would be in patients who have got herring C, who have got head at risk signs. If they're less than 7, you can do a containment with brace and periodic review. If they're more than 7, then unfortunately you've got to do some form of surgical containment procedure. So that was a brief overview of Perthes. I'm just going to take this off. I'll stop sharing for the time being so I can see you guys.
Okay, while they're thinking about the questions they're going to ask you, is there any autoimmune parts to this, or what's, I mean, apart from the vascular etiology, what brings it on and why the hip?
I'm not aware of any autoimmune etiology being proposed for Perthes. I guess it's something that we have so little knowledge about the etiology. So I'm not aware of any autoimmune thing as far as I know.
Okay, and is there any equivalence to Perthes in any of the other joints? And if not, why not? In terms of, can you give a reason or sort of a thesis as to why it only affects the hip?
Similar conditions affect multiple joints. It's not just the hip. Similar conditions, because you have essentially it's an avascular necrosis of a joint. So we have AVN of the knee, the talus of the second metatarsal called Freiberg's. You can have AVN affecting the scaphoid of the lunate. So it's not uncommon to have AVN, but I think this is the only condition that affects more generally children. None of these other conditions I mentioned actually affect children. So I guess it's slightly different from all the other avascular necrosis that we tend to see.
Okay, good. Any questions from the floor?
Stunned to silence.
Yes, stunned to silence. They're mesmerized. Okay, let me just see if anybody's raising their hands. I cannot see anybody raising their hands. Okay, in the absence of questions, do you want to go on to your arthroscopy?
Okay, I'll do that. I mean, just out of this thing, the questions that, because I examine at the FRCS author exams, and we do ask questions related to Perthes. I think the main themes that you will tend to be asked on Perthes at an exam level will be, one, the differential diagnosis. I think that is one we ask quite regularly. You'll be asked about the head at risk signs. That's quite commonly asked. You'll be asked about the principles of management, not necessarily the nitty-gritty of how you do a Salter's osteotomy or anything like that, but I think it's the principles of management. I think those are the things, and how you would manage late presentation. I didn't put the late presentation on. Late presentation really is a hip replacement you're looking at. And doing hip replacement in children is something that we loathe to do, but it can be done. There's about the frog leg lateral. The frog leg lateral X-ray of the hip is actually an X-ray. I should have put the X-rays out to see what they look like. A frog leg, you have an AP of the hip, which is with the hips facing straight at you. The frog leg lateral is done with the child lying down. You bend the hip and the knee and put the 2 feet together so that if you look at the child on the table, it forms a diamond shape of the lower limb. And what that gives you is a perfect lateral of that hip, because you've externally rotated both hips. And so that gives you a fantastic view of that. And it gives you the ability to see if there is any problems with the femoral head, especially not only Perthes, but also slipped upper femoral epiphysis is very easily seen on those X-rays. So that's what a frog leg lateral is. Any other questions?
No.
I'm looking up and down on the. Okay.
That's another question, yes.
No, that was just a
Oh,
comment.
yes, that's just a thank you, sir.
Okay. Let me get the next one up. Right, knee arthroscopy. So essentially, what is a knee arthroscopy? The word arthro means joint. Scopy is to look in, and hence that's the term we tend to use. Knee arthroscopy is to have a look inside a joint. In simple terms, it's a keyhole operation to look into a joint. And if you look back again as to when it all started, Tagaki actually performed the first knee arthroscopy in 1918. But it wasn't for another 50 years almost before we were able to perform anything using an arthroscope. And in 1962, Watanabe, who was a Japanese surgeon, did the first meniscectomy using an arthroscope. And in those days, there were very rudimentary arthroscopes that were used. Robert Jackson, who's one of the American knee surgeons, he went to do a fellowship in Japan with Watanabe, and then he brought this back to the US. And then that's when it started to become more popularized. So what instruments do we need for a knee arthroscope? I think, first of all, for an arthroscope, in general terms, there are very much the same equipment. You need a TV monitor, you need a light source, you need some power to have the light source and TV monitor. You have a fiber optic cable that supplies the light to the scope, and then the TV monitor is connected with a cable onto a camera, and then the scope itself has an eyepiece, and then the tube itself, and then you have some method of getting fluid into the knee, into the joint. So that's essentially the equipment you would need. It seems very simple, but unfortunately, all of this kit actually costs quite a lot of money. So if you look at the instruments that we tend to use, so we have an arthroscope. This is an arthroscope, and by and large, there are two types of arthroscope. There is the 30-degree scope, and there is the 70-degree scope, which is essentially the angle at the tip as to whether it looks that way or it looks that way. Then you have the fiber optic cables, which are these blue things that are there. There's a light source, a camera. This is the camera on the end of the scope, and some form of fluid management system. And then we have lots of different instruments. So this is the arthroscope itself. This will go into this bit of kit. This is something called a shaver. It's something we use sometimes to work inside a joint. So first thing we need is a stacker system. And this is what we tend to have. So essentially, that's a TV monitor. And then you have different bits that sit on these shelves. So you've got a visualization bit, which is the bit that has the light source on the camera. Then you have a fluid management system. You can do without a fluid management system if you can actually hang a bag of saline as high as you can, which will get fluid into the joint, but the pressure is quite low, and so it doesn't work that well. Then you have other bits of other things you can use. There's the coblation technology, the mechanical resection technology. These are also things that help you with your arthroscopy. So this is probably the most expensive bit of kit that you need to have. Then you have instrumentation. These are things that you would use while you do an arthroscopy, and there are all of these things that have different ends. They have graspers, you have cutters, you have scissors, you have side scissors, up, down. Then you have these are the handheld instruments. Then you have the shaver, which is essentially this bit of kit, which has, again, a thing at the tip, which rotates and therefore will shave bits of cartilage, bone, meniscus, synovium, and things like that. And then you have the electrocautery equipment, which again burns bits of tissue, which is helpful in doing bits when you do an arthroscopy. So The other bit you have is the camera, okay, and which is this bit of equipment, which is attached to your arthroscope. Ideally, if you need to be able to sterilize this so they don't keep having to cover it. If you don't have a sterilizable camera, then you can have plastic covers, sterile plastic covers, which go over the scope itself. So you don't need to sterilize the camera in such a situation. But you need a light source, okay? And it does have to be quite a bright light. We tend to use LED lights with fiber optic cables in order to visualize the inside. So as I was saying, the scope has an end. So this is a 0-degree scope, which we don't use because we do like to be able to see around corners. So this is the 30-degree scope. So it looks down. So this angle here is 30 degrees. So you can actually look around bits of corner. This is the bread and butter of a knee arthroscopy scope. However, you do have a 70-degree scope to look around, really look around corners. And these are usually used in shoulder arthroscopy. So arthroscopy, so you can arthroscope almost every joint in the body. And I think everybody's had a go at arthroscoping every joint. Knee, shoulder are probably the commonest joints that are arthroscoped across the world. We can arthroscope the ankle. The foot and ankle surgeons certainly are putting in cameras into the ankle to debride the ankle, take loose bodies out. The new thing right now is hip arthroscopies, especially in patients who have got labral tears, loose bodies in the hip. You can also do that. Technically, this is quite a difficult operation to do, a hip arthroscopy, because the hip is a very deep joint. You can do wrist and elbow. And recently, guys have been looking into the facet joints, into the MCP joints, IP joints, the mid-tarsal joints. I mean, I must say those joints are very, very small. I'm not entirely sure how useful those procedures are, but I think that those are probably procedures that are being developed for the future. So when you do a knee arthroscopy, it's usually done under a general anesthesia. You can sometimes do it under spinal anesthesia and very rarely under local anesthesia. There is a push to doing this under local anesthesia, but I will tell you that it is quite painful when you do a knee arthroscopy under local anesthesia. The next thing is use of a tourniquet. There is some debate as to whether you should use a tourniquet or not. If for those guys who've been reading the journals, in the recent British Journal or British Bone Journal in, I think it was April, there was an entire edition that was put down that had discussions about the fact that we shouldn't really be using tourniquet and how dangerous tourniquets are. It is possible to do a knee arthroscopy without using tourniquet. Usually a knee arthroscopy is done as a day case unless there are comorbidities which prevent the patient from going home the same day. 99% of our patients who have knee arthroscopies go home the same day, usually within 2 to 3 hours. So again, as I was saying, tourniquet is commonly used, improves visualization, but there is the evidence to suggest that it's unnecessary. I must say I use a tourniquet. So when you set them up, you need a side support, okay? So that it's essentially this piece which is attached to the table, and you put it on, and I will come to it as to why you need the side support. It is usually to see the posterior horn of the medial meniscus. So you need to be able to lever against that side support. So what's the advantage of arthroscopy? In the past, when we had a problem inside the knee, such as a meniscal tear, what we used to do was do an open operation, go inside and take the whole torn meniscus out. If I was to do a total meniscectomy, okay? But by doing a knee arthroscopy and doing that at the same time, what you do have is that it reduces post-op morbidity, you have smaller incisions, you have less intense inflammatory response because of the fact that the holes are very tiny, and they don't have any secondary effects of having to do a full open arthrotomy. And as I was saying, most of our patients are done as day cases. We and so it reduces hospital stay. In the past, when we did total meniscectomies, open meniscectomies, patients stayed in hospital 5 days. And also, from a research point of view, if you needed to do a second operation, it is a lot easier to do a knee arthroscopy than for you to do another arthrotomy if you needed to do anything like that, although that's very controversial. And you can do surgical procedures that are difficult to perform open. For example, if you're doing meniscectomies, it is actually easier to do a meniscectomy through a scope than to do it open. But one of the disadvantages is technically challenging. It needs a lot of practice, a lot of practice. And you're working through very small portals and using very delicate, fragile instruments which can break. You're maneuvering the instruments within the confines of what you can see. And so accidentally, you can scuff the articular cartilage, something known as scope damage. And I think in all endoscopies, that is a risk. And it can be time consuming for the people who find it difficult to do an arthroscope. But it is actually quite a quick procedure. And it requires special, expensive instruments, as I said earlier. So what are the contraindications for doing a knee arthroscopy? Essentially, if you think there's a skin lesion that may cause infection inside the joint, you should not do an arthroscopy. So for example, if there's a big scab which looks infected and angry around where your portals are going to be, don't do it. There are some relative or contraindications. So people who've got complete or ankylosed joints, you will not be able to get into it, essentially. And if you have got major capsular disruptions, there is some folks who would say, don't do an arthroscopy, because by introducing that water into that joint, because there is rupture of the capsule, there is an increased risk of compartment syndrome in those patients. In those patients, I tend to do what's called a dry scope, where you don't put any water in it and have a look, because you're trying to see, essentially assess the patient rather than carry out any surgery through that. So arthroscopy requires the concept of triangulation. This is the most important concept, and I think it's the most difficult to achieve. And in my opinion, I must say, I find that a knee arthroscopy is probably the most difficult operation to do because of this concept of triangulation. It involves that you have one or more instrument inserted through separate portals that you have to bring into your optical field of the arthroscope. So the tip of the instrument and the tip of the arthroscope forms the apex of the triangle. And then the separation of the instruments and arthroscope improves your depth perception and allows you to look around. But what you need to be aware of is that if you move the two, as in the scope and the instrument, you will get lost inside the knee, or any joint for that matter. So this is the triangulation. So this is the scope, and these are your instruments. And that's what you're trying to get at. Now, when you are looking at this, you can't see inside here. Only thing you can see is the top of the box. So you can see where this is going in. You can see where your scope is going in, your instruments are going in, and you have to, in your mind, imagine where the tip of that instrument is and where the tip of that scope is. And then be able to advance your instrument to grab hold of that item inside the box. So this is actually a system that is used for training purposes, something called an arthroscope box. And I think this is the most difficult thing to master. So hopefully I should be able to, that didn't work. Okay, I'll see if I can get that video up later on. So what are your indications for arthroscopy? In my hands, the ones I tend to do a lot of: meniscal surgery, either meniscal repair or meniscectomy, getting loose fragments of bone or articular cartilage out, something called loose bodies, to assess and treat ACL ruptures, PCL ruptures. It can be used to do biopsies of the synovium in patients who've got rheumatoid arthritis, in patients who've got PVNS, or the synovial chondromatosis. It can be used in assisting trauma surgery. So you look through that and make sure your tibial spine fracture, which is you're trying to fix, is reduced properly. I have found that procedure to be extremely difficult. And after most of the time, every time I've done that, I have to say, after about 45 minutes of trying, I open the knee and it's easier to do it open. Some people do arthroscopic assisted tibial plateau fixation. Again, my worry about that is compartment syndrome, because of the fact that you've got a scope in there, there is a fracture, you put water in, the water goes into the bone, goes into the soft tissues, and you can get compartment syndrome. Articular cartilage surgery, that's another place what we do quite commonly. You can do abrasion chondroplasty, which is smoothing out the articular surface. You can do mosaic plasty. For those who don't know what that is that you take cartilage from an area that is non-weight bearing and insert it into an area which is weight bearing where there is damage to the cartilage. There is the new concept of ACI or MACI, which is autologous chondrocyte implantation, which is a method. What you do is you biopsy cartilage from inside the knee. You then send it off to the lab. The lab grows the cartilage in a Petri dish. You then bring it back in usually 8 weeks later, and then you insert it on a membrane and stitch it onto the cartilage, and that's usually done for people who've got chondral damage. Young people tend to have that. There's other concept of microfracture, which is a way. What we do is, if you have got an articular cartilage defect, if you remember from your anatomy, is the fact that the articular cartilage is avascular and aneural, and therefore will not heal if there is damage to the articular cartilage. However, there is the so-called tide mark, which is where the blood vessel is under the articular cartilage. So what you do is you make holes through the articular cartilage into the tide mark, cause bleeding, which then forms fibrocartilage in the holes, and they heal up and give you not a normal cartilage, but an abnormal cartilage, but it works in terms of pain relief. You can use an arthroscope to do what's called a lateral retinacular release in patients who've got laterally tracking patella or patella instability, although lateral release is going out of fashion at the moment. You can also use it in patients who present with something called patella clunk syndrome after total knee replacements. And this is a condition where what you have is there is an area in the notch which forms scar tissue, which when the knee flexes and extends, the patella catches on this scar tissue and clunks, and this clunk is quite painful, and you can put in an arthroscope to deal with that. Some people do an arthroscopy before they do a unicompartmental knee replacement or high tibial osteotomy. I think the current teaching is that you don't need to do that, but most people would do stress views, X-rays, rather than subjecting the patient to an arthroscope. But I think some people still do them. I think some parts of Europe are still doing that. So what are the complications of an arthroscopy? The main complication of arthroscopy are still infection. So as I tell everybody, anytime I cut skin, it can get infected or bleed. If you are not a skilled arthroscopist, you can cause iatrogenic damage. You can damage the meniscus, articular cartilage. In extreme cases, injure the ligaments or the neurovascular structures. You can cause compartment syndrome if the pressure of your water is very high and there's a leak in the capsule, and this leaks out into the joint. There are tourniquet-related injuries, especially if your arthroscopy takes you a very long time. And I was saying that when you're doing this, those instruments are actually quite small and quite thin, and sometimes they can break, and you may have to go in there with your arthroscope and find that broken piece and get it out. So how is it, the procedure itself? So how do you position the patient? Okay, patient is usually positioned supine. You can either do this on a trolley or on an operating table. I tend to do them on a trolley, which has the ability to attach the side support. So you have this side support attached in order for you to be able to put a valgus strain on the knee. Before you start the operation, you must always do an examination under anesthesia. And what you're trying to find there is to see if you've got full range of motion or not. So for example, a patient presents with a locked knee. When you put the patient to sleep, it unlocks. So you need to know that actually it may well be a supratentorial reason why they have a locked knee. So you examine the range of motion. The second thing you want to look at is ligament instability. So you carry out an anterior draw test, a Lachman's test, and a pivot shift test, as well as a posterior draw test to assess the anterior cruciate ligament and the posterior cruciate ligament. You can also assess the medial and lateral collateral ligament to see whether it opens up or not, and to see whether there is an endpoint to all of these. Because all of these will determine what you will do to that patient in terms of management. So the next thing is making the portals. And it is vital that you know where to make the portals. If you make so the standard portals are the anterolateral and the anteromedial portal. Those are what we call the workhorse portals in knee arthroscopy. And you need to be able to make it in the right place, because if you make it too low, so that's the patella, that's the tibial tuberosity, that's the patellar tendon, that's the joint line. And usually what I would do, so that's the fibula head, what I would do is put my thumb on here. So I'm right next to the patellar tendon, and above, so my thumb is on the tibial, on the joint line, on the tibial, on the tibia, on the upper surface of the tibia, and then I will make my incision one thumb breadth above the upper surface of the tibia. And the reason you do that is that you don't want it too low. If it's too low, your incision will go through the lateral meniscus. So if the chappie didn't have a lateral meniscal tear, he will have one now. So you need to not cause any damage there. If you make it too high, so somewhere about up here, the patella gets in the way, and so you can't see the lateral side of the knee, or the medial side of the knee. So that is your anterolateral portal, and that's your anteromedial portal. And then there are other portals, and we'll come to that as to why you would do other portals. So as I was saying, the first portal is the one you would do first, which is the lateral portal, anterolateral portal, one thumb breadth above the tibial plateau. This avoids damage to the lateral meniscus. I usually use a number 11 blade. It's not essential, but a number 11 blade is what I tend to use. So when you look at that bit, you actually feel this as being a soft spot. So the upper bit is the femoral condyle, the lower bit is the tibial condyle, and this area. But you want to be sort of in the middle of that, or the lower third of that space. You then put in your arthroscope. So the arthroscope is put in fully. So don't put it just a little bit in. If you do, it will stay under the skin. And especially if you have a patient who is rather fat, and there's a lot of fat around the knee, you will go into the subcutaneous tissue. And as you open up your water, it'll just simply go all into the subcutaneous tissue and can cause compartment syndrome. So you put that in fully till you hit the medial femoral condyle. When you've hit the medial femoral condyle, you know you're in the joint. So once as I was saying, once you put it, you've hit that, you then turn the arthroscope such that it goes into the suprapatellar pouch. You put it into the suprapatellar pouch and move the camera now laterally and medially and make sure it is free. If it is free, then that signifies you're definitely in the joint. That's when you start to fill your knee up with water, okay, so that so you can then see inside. You then attach your camera onto it to look inside the femoral, into the joint. You then go on to doing your medial portal, which is your instrument portal. Again, you'll be able to feel that there is a soft spot on the medial side. Again, it needs to be a thumb's breadth above the tibia. Again, so that you don't damage the medial meniscus. There are two ways of doing this. You can do the so-called soft spot. So you get to that spot, stay very close to the patellar tendon, and then make your incision with your knife pointing away from the tendon, so that if your knife does slip, it doesn't cut the patellar tendon. Or you can use something called the needle technique. And what the needle technique is that you've got your scope inside, you put the needle in where you think it should be, and see whether you can see the needle from inside. So that can be done as well. So once you've had your scope in, and through the medial portal, what you're going to do is put your arthroscopic hook, which is the instrument you would use to feel the inside of the joint. I always tell all trainees that you should have a sequence by which you look inside the knee. Don't be haphazard, because if you are haphazard, you will miss something, and therefore it's not a full arthroscopy. Because arthroscopy is regarded as the gold standard for visualizing the inside of a knee. So when you look inside the knee, what I tend to do is look in the suprapatellar pouch first. So that's the suprapatellar pouch. You're looking in there. That is the patella. That is the trochlea. Okay. If you then bring your scope back a little bit, you will see the articulation between the trochlea and the patella and the trochlea. Now, as we said before, is that your scope is 30 degrees. So that means that if your scope is pointing up, you look at the patella. If you turn your scope round 180 degrees, you will then see the trochlea. So once you've assessed the suprapatellar pouch, that's where we usually tend to see loose bodies inside. That's where you would tend to see patients who've got synovitis or they have PVNS. That's where you will tend to see that. You then have a look at the patella to see if the patella the tracking is okay. You can actually flex and extend the knee to see if the patella sits in this trochlear groove or not. You can look at the patella surface to see if there's any arthritis. You can look at the trochlea to see if there's any arthritis. The other thing you want to look at is how deep is the trochlear groove? Because if the trochlea is flat, something called trochlear dysplasia, those are patients who are more prone to having recurrent patellar dislocations. So the next thing you want to do is, once you've looked at the patellofemoral joint and the suprapatellar pouch, you then want to go to the medial side, okay? So what I tend to do is go into the medial, so I turn at this point, while you're looking at the suprapatellar pouch, the knee is in full extension. You then move your scope going down the medial gutter and then into the medial compartment. So once you do that, you then need to bend the knee to 90 degrees. You hang the leg off the edge of the table. The other thing I forgot to say is that you stand during this operation. You usually do not sit down. So what you will then see inside is the medial meniscus. So this is the medial meniscus. That's the femur. And that's the tibia. And this is the hook that we use to have a feel of all the instruments, of all the structures. So we will then use the hook, get it round to the most the most medial part of the medial meniscus, and see whether you can pull the medial meniscus or not, and see if there's any tear. The medial meniscus is divided into three. There is the posterior horn, the body, and the anterior horn. And by moving your camera around, in other words, the direction of your camera around, you can see all three structures. In order to see the posterior horn of the medial meniscus, what you have to do is to apply a valgus stress. So what you're doing is that you put your body between the table and the leg, and you're leaning against, so the leg is then leaning against that side post we had, so that you can see the inner side. So this view is without the valgus stress, and that view is with the valgus stress. And you can now see that the posterior horn of the medial meniscus, you can see, and that's actually a photograph of what that looks like. And you can see the whole of that's the posterior horn of the medial meniscus, and that's the body of the medial meniscus. You can see all of that. Commonly, degenerative tears tend to be in the posterior horn. But then there's also patients who have got ACL ruptures, and there is something called a ramp lesion, which is separation of the posterior horn at the meniscus, where the meniscus actually attaches to the synovium. And that you will see a separation here. Okay, and that's called a ramp lesion. And if you are doing an ACL reconstruction, that ramp lesion needs to be repaired at the same time as your ACL reconstruction. You then look at the ACL. The next thing to say is that the ACL is a relatively vertical structure. So when you're looking at the ACL, what you need to do is have your camera either looking vertically up or vertically down. So if you're looking vertically up, as in this picture, that's the notch. That's the anterior cruciate ligament attaching to the lateral wall of the notch. We've got the hook round it to feel how tense it is, to see that it is attached and it is not slack. In some people who have an ACL rupture, it may actually detach there, and behind this bit of fat is the posterior cruciate ligament. And this detaches there and attaches there. So you look inside there, it looks as if your anterior cruciate ligament is there, but actually is attached to the wrong place. And I'll show you some pictures of that. You then turn the scope round. So it now is looking vertically down. And this is looking at the tibial attachment of the anterior cruciate ligament. Now the anterior cruciate ligament is attached between the tibial spines, or attached to the tibial spines. And so that's what you're looking at, because the rupture may be at the insertion on the tibia. So you then want to look at the lateral compartment. So what you then do is put the scope into the lateral side of the knee. So you're still inside the knee, you just push it to the lateral side of the anterior cruciate ligament, put the leg into something called a figure of 4 position. This opens up the lateral compartment, and then you will be able to see the lateral compartment. You can put a bit of pressure like this with your hand, and this opens the lateral compartment even more. And then you will see this. And that is the posterior horn of the lateral meniscus. That's the body, and that's the anterior horn. And that's the lateral femoral condyle. That's the lateral tibial condyle. And then again, the same thing you would do is you get your hook around it to see if the meniscus is intact or not. And you would know that the lateral meniscal tear usually is a bucket handle tear because of the fact that in here, there is an area where the lateral meniscus has a hole in it. And that's where the popliteus tendon goes through. And therefore, it is more likely to tear all the way around. And I'll show you some pictures of that. Okay. And then you tend to look at the gutters. So which is the space just medial to the medial femoral condyle and lateral to the lateral femoral condyle. This is also an area where you tend to see loose bodies. And here's a picture of a loose body in the lateral gutter. And so you need to fish those out. So you can do additional portals. And why do you need additional portals? Because sometimes you will find that with just those lateral and medial portals, you can't get to all the places. So sometimes you will need a higher lateral portal, and that is if you want to look at the tibial spine. And that is better if you do a higher lateral portal. A higher medial portal is useful when you do an anterior cruciate ligament, because you can then get round the femoral condyle into the notch and see the back of the lateral femoral condyle, because that's where you want your ACL to be attached. But you do need to be able to see that, something called, you need to go behind what's called the residence ridge. So here are some of the additional portals. So you can have a posterior medial portal. Now you do a posterior medial portal if you want to see into the very back of the knee. So for example, you're doing a posterior cruciate ligament reconstruction. You need to be able to see to the back of the tibia, because that's where your PCL reconstruction tunnel is going to be. So you will use that. You can use a superior portal, a superior medial portal, and a superior lateral portal. The superior medial portal is usually put in if you require a drainage tube. Sometimes it's bleeding a bit inside the knee and you want the water to come through and flow out quickly so that the blood is taken out. You put in a medial portal and a medial tube, which is attached to a tubing into a bucket so that the water drains out. Then you can do a superolateral portal. And essentially, when you do that, you're trying to, for example, you want to get into the suprapatellar pouch. There may be a loose body in the suprapatellar pouch, or you may have a patient who's got PVNS and you need to do a synovectomy. And it's easier to go directly into the suprapatellar pouch and do such things. There's one additional portal which is not mentioned here, which is the patellar tendon portal, which is going, so if you look at the patellar tendon is here, and what you do right at the inferior pole of the patella, you make a vertical slot portal, so you can actually go put instruments in through that. And that's very helpful, especially if you need an additional instrument. So for example, you're doing a medial meniscal repair or lateral meniscal repair. You need one instrument to hold the meniscus in the right place and a second portal to get the stitch in to repair it. So that is quite helpful. It's also sometimes helpful if you want to do an ACL reconstruction, because you're going straight onto the ACL, and you can see right to the back of the knee. So that, but know why you're doing these portals. So here's a view of the medial meniscus, and essentially what this is showing is a tear of the medial meniscus. So that's the rest of the meniscus there. This bit is torn off, and you can see the big split there. So in this sort of meniscal tear, more or less, you've got to trim the meniscus out. As again, the meniscus does not have a blood supply, or let me rephrase that. It is only the peripheral bit of the meniscus that has a blood supply. The more central bits don't have a blood supply, and this is definitely in the central area. So if you repaired this, as it has no blood supply, it will not heal. So you've got to go in and take this torn bit of cartilage out. So this will be a situation where you'll be doing a medial meniscectomy. On the other hand, you could have this situation. So that's the notch, and the whole of the meniscus has come out and is now sitting in the notch. So that's called a bucket handle tear of the medial meniscus. So it's attached at the back and in the front, and this whole bit is detached and has come off. And in these sort of situations, especially in young patients, you would aim to repair the meniscus back to where it is. There is a 20% failure when you do a meniscal repair, but if you have somebody who is, let's say, 20, is a footballer, if you take his meniscus out, he is more likely to develop post-traumatic arthritis in that knee. His career is likely to finish sooner rather than later, and will end up having a knee replacement at a young age. You can take loose bodies out. So that's a loose fragment, and that to me looks like a fragment of articular cartilage that's floating around. It's always great fun to run after these, because the water you're pouring into the knee will pressurize this loose body to run away from you. So you've got to be careful as to how you get this. So the technique is quite interesting. Some people will use a needle to hold it in the right place, hold it, and then use your graspers to take it out. Others will just simply go in and take it out. Or others will move the loose body into the suprapatellar pouch, where it's easier to get hold of it. This is an ACL tear. So this is what the ACL should look like. This is what it looks like. So that's torn. That's the notch. It should be attached there. All the fibers have gone. And the other thing you can see here is that this is also a torn ACL. It should be attached up here, but it is detached from there. It's lying here. But the most important feature that it shows that the ACL is ruptured is, if you look at it, it does not show any blood vessels on it. If you look here, there are these red bits, which are the blood vessels on the ACL. That does not have any blood vessels, which means that is a torn ACL. And this is one where we've done an ACL reconstruction. So that's a hamstring tendon that's in there, and it's gone into the notch. So you can do that. So this is a lateral meniscal tear. So that's the lateral meniscus. That's the lateral femoral condyle. There's a split down here, all the way there. An attempt has been made to repair it. So you do this sort of repair. We have lots of instruments now, which will allow you to do this meniscal repair one-handed. You don't actually need the old method of getting in and out and out. What you actually go in and you simply, it's a trigger system, and you just can repair the meniscus very, very easily. You can also look at chondral defects. So if you look at here, that's nice articular cartilage. And if you look here, it looks like somebody's taken a chunk out of it. You can see bone at the bottom of the defect. So this is a patient who had a big chondral lesion, has had a meniscal tear as well. You can see that. So he's in trouble. With this sort of situation, one of the things you do need to look at is his anterior cruciate ligament intact or not? So then you have the further thing of having osteoarthritis in the knee. So when you look in there, there's this whole big area where the cartilage is denuded. We're putting the hook on there, and when you actually put the hook in and run it across this bit, it does feel like you're scraping it. Okay, so this is a chap who may require knee replacement at some stage. Then there's PVNS. PVNS is more common in the West, in Europe. It is a condition where there is synovitis of the lining of the joint or the meniscus. It's the pre-cancerous condition, and therefore you've got to go in and take out all of this stuff. So it looks like this at the end. It does look as if there's, plants growing inside the knee. They're usually red, or brown, but there can be other colors as well. Hence, they're called pigmented villus nodular synovitis. Then, how can you improve your arthroscopic skills? Okay, so first and foremost, you can go to one of these courses that you can do. So there are these bits of kit that are available. different companies provide them. Arthrex is the commonest one that provides them in the UK. So you have a screen like that. They give you the scopes, and then you pop your scope in and have a little feel and see whether you can play with it and to get your triangulation right. But there are other ways of doing it. This is quite an expensive method. You can build it up in this sort of manner. I found this on the internet. I haven't actually used it, so I have no experience of doing this. But this is essentially a drainage tube, and you put a hip and a tibia and a femur, attach them all together, put them inside, make two little holes in the drain. Of course, you need to have the arthroscope and the monitors, and you look inside and see how well you can triangulate. Okay, so this is done in courses, in different courses, and as I was saying about using arthroscopic boxes, as I showed you earlier on. So how can you improve your arthroscopic skills? I think my generation of surgeons were disadvantaged because the current generation of surgeons use these bits of kit called X boxes, and they are very good at it. And by using the Xbox, Nintendo, and other such PlayStation and things like that, one of the things that the current generation of surgeons have got is that they have better hand-eye coordination. And that is what you need when you do an arthroscopy. Okay, so one of the methods to do this is to go home and play on the Xbox. You can tell your partner that actually you're working, not playing on the Xbox, even though you're playing Grand Theft Auto or FIFA or whatever you're playing on that. In my view, this is my view, and it may not be right, but I believe that after you've done 50 arthroscopies is when I say that you're able to assess a knee joint. When you have done 100 arthroscopies, that's when you're able to perform a meniscectomy safely. And when you have done 150 arthroscopies, then that's when you should consider that you may be able to do an ACL reconstruction. That those may well be my views and may well be biased. And that's what I tell my trainees. Any questions? Again, that was a quick thing. The other thing I will say is that learning how to do an arthroscopy by going to courses and attending things like this are probably not that helpful. It is really to get your hands dirty and do them. And that's the only time you would be able to become proficient in doing knee arthroscopies. Thanks a lot. Any questions?
Saqif, thank you very much. That is a wonderful thing. I can say, I can feel your pain from a guy who used a laparoscope in the abdomen, and the abdomen now looks like a vast football field compared to the fields that you guys use. And it's easy to manipulate for us. But that's a wonderful thing. It's a very skillful thing that you're using. While they're thinking of their questions, I'll probably, when you were talking about the lateral meniscus repair, I just saw something that looked like a cross stitch.
Yes.
And you're saying you're using that one-handed. So you're not using stitches at all.
So what it is actually an instrument which has, what you do is essentially you push it, it has a needle at the end, you push it into the meniscus, fire it, so it has a little plastic piece which catches on the other side of the meniscus. When you then pull it out, it's attached to the meniscus. You then do the same again on the other side of the tear, put it in, fire it, it then tightens that up, you take it out, and you can actually do a full cross stitch with that.
I see.
So it is quite a useful, so you can do up to 5 stitches on instrument.
Yeah, that's interesting because obviously as you progress, we have to learn how to stitch
Yeah.
and the luminally. And obviously most preferably because as I get it now that you cannot see the entire joint from just your lateral and medial ports.
Yeah.
You have to, if you want to see the entire joint, you have to go in and put some more ports in.
Yes, you do.
Yes, okay. Does
So
anybody have, sorry, go on.
when you do a laparoscopic repairs, do you actually use sutures to do it? Are there no instruments that will let you do them? I mean, when I did general surgery, there were things like, what, that TA55 or something like that.
Yes, no, the staples are slightly different things. So
Yeah.
for the bowel anastomosis, it's staples we use, but we
Yeah.
have the advantages that you slightly don't have, in the sense that I can do extracorporeal anastomosis.
Right.
So I've done all my mobilization, and I
Yeah.
want to join the bowel together. I bring it out and put the staples in. So the argument is that you're going to have to make a small cut to bring out the specimen anyway.
Right. So
In that small cut, you're going to make a specimen. You can, so you've done all the dissection inside, and then you can do your extracorporeal anastomosis with staple guns.
right. Okay.
Now, for something like a perforated ulcer, gastric ulcer, which
Yeah.
will close up, that I have to use needle and stitch inside.
Right.
And suture and closer. So that will use needle and stitch inside. I'm just trying to remember what I did a few days ago, which I had to use needle and stitch as well to close.
Okay.
So for some people who want to do intracorporeal anastomosis, some of them can get away with staples, but some of them would actually anastomose using needle and stitch as well.
Right. Okay.
Yeah. So we have an awful lot. We have a much easier life than you guys do.
Right.
Apart from space, in the sense that we still have to take the specimen out from a hole, and then for that reason, we can do a few things outside that to complete the operation rather than do inside.
Right. Okay.
Right. There's some questions before we go to these new people who've asked questions. Somebody asked you just when you started off, you're talking. So that person, Oluwasegun Kolade, asked, at what age is it safe? So that's going back to Perthes disease. At
Right.
what age is it safe to or good to do total hip replacement for this set of patients?
Ideally, the patients anybody who has a hip replacement, ideally should be over the age of 60. But we do hip replacement in younger patients. Nowadays, a lot of patients are having hip replacements between the ages of 40 and 60, and that's not uncommon. But the whole thing is that a hip replacement is like your car tire. It doesn't last forever. So most hip replacements will last for somewhere between 15 to 20 years in the elderly and 10 to 15 years in the younger patient. Now, if you have a young person, let's say 40, that patient has to have a hip replacement. That means by the age of 50, we'll need a redo of that hip. And that second hip is significantly more difficult to do, with significantly more bone loss, and the likelihood of survival is less than the primary hip. So if you keep doing that on and on, there will come a point where we don't have enough bone stock to do a hip replacement. And at that point, the treatment may have to be an amputation. And in a hip, it's a disarticulation. So, which is why we would like not to do this. However, I will say that that's based on technology that currently exists. If we look back 25 years, the technology that existed 25 years ago was completely different. And today we are quite happy. So 25 years ago, nobody would contemplate doing hip replacements in under the age of 60, but nowadays we do, because our technology has improved that much more. Patients are getting hip replacements in their teens and 20s, but we know that those are going to be hard work through the rest of their life. We would like them to have at least achieved fusion of all their physes before you do a hip replacement. All their growth plates have healed, have closed before you do a hip replacement. I don't personally do young hip replacements, but as many of you would know, I work in Manchester, and right around the corner in Manchester is where we have Wrightington Hospital. And Wrightington Hospital is where modern hip replacement was born. So Sir John Charnley, who is the person who designed the first hip that works, was a surgeon in Wrightington. And so we do have a lot of specialist hip surgeons who are doing young hips, who are doing replacements in children, and well, I would say children, sort of 18 years and above. But the whole idea would be to try and prevent the requirement for a hip replacement for as long as possible.
So let's just going on that. So what fails when we've done a hip replacement? What actually fails 10, 15 years down the line?
So usually the hip replacement is, there are two ways of fixing the hip replacement, the prosthesis. We can either use bone cement, or it can be what's called an uncemented hip. So in the bone cement or the cemented hip replacement, what tends to fail is the cement.
I see.
Because cement is grout in your bathroom, and at some stage the tiles will come loose. And it's not that the tiles have not broken, usually. It's usually the tiles have come loose and are coming off. And that's when you need to get a new bathroom fitted. And exactly the same thing, that's when you need to put a new hip in. In the uncemented hip, that's where the fixation is biologic. So there is a substance that is on the hip replacement prosthesis itself, usually hydroxyapatite or something like that, so that bone grows into the metal. So the philosophy behind that is that that will last longer and patients are less likely to have loosening. But unfortunately, even in those, they loosen. And again, the thing that tends to loosen most is usually the stem. The femoral stem is what tends to loosen. But the cup can loosen as well. The other thing that can sometimes be a problem is the articulation. The hip is an articulation between usually metal and polyethylene, which is plastic. And again, the plastic over time, when it's moving around, will wear away. And slowly there is no plastic left. And then again, that becomes, so it'll then fracture and will need to be redone again. So those are the things that can fail. So lots of things can fail in that respect. But generally speaking, it's the fixation that fails.
Okay, and then one more, because I mean, I don't know whether you watch this dancing thing that happens in,
Which
yeah,
one?
as the dancing program. I can't, the name escapes me now.
Oh, Strictly Come Dancing.
Yes, Strictly Come Dancing, and Rebel Hallways had a hip replacement last year.
Yes.
And he's about in his 50s. So my question is, does the level of activity and effort that you put on the replaced hip, does it affect the longevity? So if you have a new replacement and you're just using it to walk 10 yards every day, or you're dancing with it as Rebel Hallway does that matter?
It does. So Andy Murray, for example, his hip will not last very long.
Okay.
Because he's playing in the US Opens, and so there you go. He's going to wear away. I mean, the hip replacement and knee replacement is very much like your car tires. So if you drive, I don't know, 2,000 miles a year, your tires will be running for 2 or 3 years.
Mm.
If you do 20,000 miles a year, next year you're changing your tires.
Yeah, I know that feeling. Okay, I've got a question here which says, thank you for the presentation, sir. What are the practical guidelines to follow in order to prevent breakage of instruments during arthroscopy?
Well, for the main thing is, first of all, have the right instruments. Make reasonably good size portals so that you're not pushing the instrument in. And if at any point in time your instrument has bent, get rid of that instrument, because that instrument is likely to break when you put it inside. The commonest instrument that tends to break is the hook, because that is the thinnest instrument we use. And so avoid using an instrument that has been bent several times. Make sure the other thing that I tend to do is that when you make, especially when you make the medial portal, which is your accessory portal through which you're going to put instruments, as soon as you made the cut with the knife, use a blunt instrument, and usually the trocar of the arthroscope is a good instrument to use to create the passage into the medial portal, so that that passage goes straight into the knee. So you're not pushing against capsule and things like that with the hook, because if you do, it is likely to damage your hook as well. So avoid using, if you take those precautions, generally speaking, you wouldn't have a problem. I mean, I've never had a broken instrument in the knee so far, but I have been asked to come in to fish one out of the knee, and it's fairly easy to do it, but it's not something you like to do.
Okay, any questions? While they're thinking for their last questions, just one more thing. You always spoke about repair of ACL. And
Yeah.
from my distant memories, repairing ACL used to be a big thing because I work for a guy who did that. So is there what's the literature says on arthroscopic repair of ACL versus open repair of ACL?
There isn't much difference between arthroscopic and open. Most people have now gone to arthroscopic,
Okay.
and that's more for pain relief rather than for the procedure itself. Because if you imagine, it's actually easier to do it arthroscopic, because what you see is much bigger. Whereas if you do an open, you've only got a small hole to peer through. So it is easier to do it arthroscopically in that way. But in ACL reconstruction, what's more important is what you use as a graft.
Okay.
Whether you use a hamstring tendon graft or a patella tendon graft or an artificial graft, there is great debate in all of literature as to saying which graft is best. And each one of us have our own views about it, I think.
And how do you get the grafting?
So so what you tend to do is that you have the two portals through which you're seeing the stuff, but you make a hole over the medial side of the tibia where you will get the graft out of the hamstring. So if you remember where the gracilis and semitendinosus inserts in the medial side of the upper tibia, saved grace before T was one of the mnemonics we learned when we were in UI, which is where the insertion of the three tendons are. So you make a hole there, you will get the graft out of that hole, prepare the graft, and you use that same skin incision to actually drill a hole into the middle of the tibia. And there are instruments, guides that let you do that. And that's the only incision you have. You pass it in, and then you pass it across to the other side as well in the same way. And there are, again, instruments through which you can put screws and everything else in to hold it in place. Okay.
We've got a couple of questions. First one is coagulation disorders, sorry, I'm scrolling a bit too fast. It's got a contraindication for emergency knee arthroscopy.
It depends. Technically, I don't think it is. I don't think the question is why.
Oh, sorry, I've mixed the questions. Is coagulation disorder contraindication for arthroscopy considering the technicalities?
No, it's not. It's not. If somebody has coagulation disorder, what I'm guessing is that you're asking if the patient is on some form of blood thinners like warfarin or something like that, and the INR is 3 or 4. Not really. What you do have to assess is that arthroscopy essential, or can you reverse the coagulation problem prior to doing your arthroscopy? Because if you imagine, there is very little that would account for or be an indication for an emergency arthroscopy where you cannot wait for the warfarin to be the effective to wear off. So I wouldn't see any reason why you would go in. It's technically more difficult, but you can't see anything. There's blood, it's bleeding. So you prefer not to. But if push comes to shove, then of course you can do. But it's technically more difficult.
Okay, it actually goes into the very next question, which is what are the indications for emergency knee arthroscopies?
So as far as we are concerned, I don't think there is any indication for an emergency knee arthroscopy. When I say what I mean by an emergency knee arthroscopy is something that will be done at 2 o'clock in the morning. There is no indication, which is why we are always behind the general surgeons if we need to go to theatre in the evening.
The right place it should be, go on.
But there are indications for doing urgent arthroscopies, so which means that you should try and do that within the next day or two. So in a patient who's got a locked knee, and a locked knee is when a patient is unable to straighten the knee, and the reasons for that is usually there is a piece of bone stuck between the femur and the tibia, a loose body, or the patient has a bucket handle tear of the meniscus such that the meniscus has flipped over into the joint and is acting like a doorstop. So you can't straighten the knee. So in that situation, you need to go in early, not put them on the back of a waiting list, come back in 6 months to have that done. Because if you leave that patient in that amount of flexion, they will get a fixed flexion deformity in the future. So usually if there's a patient who has a locked knee, we tend to arthroscope them early. So within the next day or two.
Okay,
So,
what are the guidelines to follow when there's sudden primary hemorrhage obscuring vision, especially if a tourniquet cuff has not been applied?
So I'm not aware of any guidelines per se, but you will go through the same protocols of any major bleed. So in that situation, you need to find out where the bleeding is. If major hemorrhage, I think you're opening that joint in order to see what you can identify the source of the bleeding. Commonest source of major bleeding in a knee arthroscopy would be the popliteal artery. You need to be able to put up a tourniquet. In that situation, you get a tourniquet, stick it up, and give you better vision. Get hold of the vascular surgeons, but I think the vascular surgeons need to be informed that you've done some rogering of it. That's when vascular surgeons get very upset with us. By and large, I think you've got to abandon your arthroscopy at that point, open the knee, and find out where on earth this is coming from. But I would say, apply the tourniquet first, get hold of the vascular surgeons, and with them, decide what the best approach is going to be. Because it may be that you don't actually want to do an anterior arthrotomy. What you actually want to do is go posterior, because that's where the vessel is.
Okay, I think a couple of last questions. From the same person, diagnostic arthroscopy is no longer a very common procedure. What's your take, sir? And
Absolutely.
sorry?
Absolutely. Diagnostic arthroscopy should never be performed. Because if you're doing a diagnostic arthroscopy, which means that you're doing an arthroscopy to have a look, we have MR scans which will give you the same information. So you do not need to subject a patient to a general anesthetic and a procedure with its risks where you can actually do an MR scan. I agree that the MR scan is not 100% sensitive and specific, but that is a better option than going in and finding that there is nothing wrong in the knee. So diagnostic arthroscopies is not something we do. There is one place where you may call it diagnostic, which is in patients you're considering whether they'll have a unicompartmental knee replacement or not. You may consider doing an arthroscopy, but I think most people at the moment have gone away from doing that and will not do a diagnostic arthroscopy. And the next one was whether you should do it for a degenerative meniscus.
Yeah.
And again, the answer is no. If you have a degenerative meniscus, especially have a posterior horn tear of the meniscus due to arthritis, there is no benefit of doing an arthroscopy. In the presence of arthritis, if you do an arthroscopy, what the evidence in literature is that you're actually worse off than if you didn't do the arthroscopy. And if you read the journals, in the 90s, the United States of America had a lot of patients who had arthroscopy for arthritis of the knee. In 2001, if I remember correctly, there was a paper that was published, I forget who it was published by, but it was published in the New England Journal of Medicine from Baylor College in Texas. And what they did was to look at, they did a randomized controlled trial comparing a sham incision, which is to make 2 little incisions in the knee, and compare that to doing a proper arthroscopy in patients who had established knee arthritis. And they found that there was no significant difference in the 2 groups. And since then, there has been lots of literature, lots of guidelines to say that patients who have got arthritis should not be having an arthroscopy. Some people have argued that if they have a meniscal tear with mechanical symptoms and some arthritis, not established arthritis, in other words, the joint space is not completely gone, in that situation, you may want to consider an arthroscopy to deal with the mechanical symptoms, which is locking and giving way. However, as I said, that if you do an arthroscopy in those patients, they tend to have more pain. And if we did an arthroscopy in such a patient, we need to warn the patient of that. The main thing that tends to happen when you do an arthroscopy is something called quadriceps inhibition. So immediately post-op, after a knee arthroscopy, if they have arthritis, the quadriceps for some reason tend to become weaker. And if the quadriceps are weaker, it means that they do not achieve full extension when they walk. And if you imagine walking on a bent knee, the muscles tire more quickly, and therefore they tend to have more pain. So at the moment, arthroscopy in the presence of arthritis, even with degenerative meniscus, is so-called contraindicated.
Thank you very much. Thank you very much, everybody. Thank you very much to Saqif or to Mr. Hossain for this wonderful educative sessions. Please, 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 can you please all go and fill your feedback forms? Thank you very much. Saqif, thank you very much.
Thanks. We'll see you next week.
Next week, yes, see you next week. I was wondering what's happening next week. Yes, see you next week. Thank you very much, everybody. Have a nice weekend.
Thank you, sir.
You're welcome.